is being held, right? We got that. This meeting is being held virtually and is hosted by the Utah Department of Health Center for Medical Cannabis, based here in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded, as you just may have heard. And a recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be prepared of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after approval. So we do have, we've just sort of given you a brief roll call, and Melanie will make note of the board members on the call, as well as make note of those who are from the public who are appearing. So thank you. And then we do have our wonderful Utah Department of Public Health staff, and there's Dr. Red. Good morning. So we've got a full complement, with the exception of Misty, who is with us by proxy this morning. So we've got Dr. Woolsey, Director of the Department of Division of Family Health and Preparedness. Thank you, Dr. Woolsey, always for your attendance and your upbeat personality, and Rich Oborn, the Director of the Center for Medical Cannabis. And then you've heard me mention Melanie, who has been doing all the heavy lifting for us administratively, and you all should be aware of that. And thank you, Melanie, for that. We do welcome any visitors to our virtual meeting at this time. If you're logged into the meeting with a phone number and not a name, please type your name in as a comment, or state your name now so we can add your name to the meeting. But actually, I'd prefer you just put it in the chat and Melanie will pick that up. If you are participating as a visitor and not as a board member or department staff and wish to make a comment during the meeting, please select the raise your hand function, which you'll see at the bottom of the screen. And I'll do my best to call on you in a timely manner if we, depending upon the circumstances. But at the end, we'll always open up the session for public comments to the extent the time allows. We appreciate your thoughtfulness. You've always been a very welcome addition to our meetings, and I really do appreciate that over the last few years, we've had a great deal of support and thoughtful input from you. As a courtesy to everyone participating in the meeting at this time, we'd request that you place yourself on mute unless you are speaking to the group. Board motions and votes will be recorded in the minutes, and we will now proceed with the agenda. So let's see, I'm just curious, that takes 3 minutes for me to read through. I gotta tell you, I've been working on my New York diction, and so I'm 30 seconds ahead of what it used to take me. My goal is, by the time I finish my chairmanship, is to get this done in 2 minutes. So in one breath. So that's my goal. All right. We have our agenda, and we've done our welcome, and we do need to approve the meeting minutes from the September meeting. So if I can have a motion for that, we will do this by show of hands. It just makes it a lot easier since we can see everybody on the screen. If I may
Harry?
Yes, Brian.
I didn't get a copy of the minutes in the email. Did everyone else get a copy besides me?
Melanie, I do recall them coming out.
I did, yeah.
Okay.
And just a comment on meeting minutes. Melanie has been, very diligent in doing exhaustive minutes, but because these are recorded, I've asked her to, in editing them, just pare them down to essential key points, so that they're not overly burdensome, and there's no cause for either ambiguity or comments that may be mistaken. So there are recordings of this. If anybody ever wants to go back, they can. So these are briefer but key point minutes, as I think good minutes should be. So thank you, Melanie, for adopting that standard as well.
I'm emailing them right now to you, Brian.
So I'll put that on hold for a minute. We'll come back to that in just a second. So I tell you what, let's do this. Let's proceed. Is Stephanie with us? Yes, she is. Hi, Stephanie. Stephanie is a special guest this morning, and she or someone in her capacity will be meeting with us on an annual basis in order to open meetings training. This is a function of state institutions or organizations where we do have open meetings, and so she's going to orient us. And Stephanie, did you hear my introduction? Did I pass muster on my obligations?
Perfect. In all the committees I've sat on, that's the best one I've ever heard so far this year.
Well, the Cannabinoid Product Board and its administrative leadership take great pride in dotting the I's and crossing the T's. So Stephanie, why don't you introduce yourself a little more fully? And you've got 15 more minutes to go, so we've got plenty of time, and take your time. And Dr. Odell has just joined us. He was going to be following us on his update on cannabis for cancer pain. Dan, welcome. We'll welcome you formally in a minute. We can start with Stephanie Saperstein, and here you go.
So I think that this is not the substantive part of the meeting. And based upon the introduction, I don't think I'll come anywhere close to needing 15 minutes to do this, since the introduction, you got a pretty good example of what needs to be done on open records. My name is Stephanie Saperstein. I'm the section director of the health section of the Utah Attorney General's office, that we advise the Department of Health and any of its statutory committees that is created in Title 26. Dave McKnight, who used to be the AAG assigned to this committee, has moved on. We were very sad to see him leave, but the Department of Environmental Quality needed him to establish the above ground storage tank program that was recently enacted by the legislature. So we are in the process of finding somebody to replace him. For the time being, I will sit in and advise however little as you need me. I've worked with Rich Oborn since the beginning of the medical cannabis program. And so I'm familiar with the subject, somewhat familiar with the subject matter at hand. But let's get down to this so you can get on with the substantive part of your meeting. The Open and Public Meetings Act is the act that is required by any government agency or affiliated government agency, so to comply with, so that the government's business is done in public. The reason for it is so that the public body provides public notice to the public so they can attend. They have to provide it within 24 hours, as was done here, along with an agenda. This committee must, once it's provided or published its agenda, it must follow the agenda, and any decisions that are attempted to be made in a meeting that is not included at the agenda would not be valid at that point. So the one thing I can encourage you is, do not deviate from your agenda that has been published. You can discuss it, but you can't make decisions on it at any point, and you have to push it to the next meeting. It becomes a nightmare if you do. I know you may be anxious about doing it, but we've had firsthand experience about committees who have made decisions on items that were on their agenda, and we ended up in court, and it had to be redone all over again. And that's not something this committee wants to do, because it slows you down from getting the work done that you need to. You're required, this committee is required by to provide public notice of the meeting, as I said, at least 24 hours, and post it. This committee and the Department of Health committees uses the state public the website. You must make minutes and take a recording of this public body. On the open portions, your draft minutes are required to be made available to the public within 30 days, and the approved minutes and any public materials distributed at the meetings must be published within 3 days after approval, be on the Utah Public Notice website. I'm assuming I sent Melanie a handout Did everyone on the committee get the open and public meetings handout? So I'm not telling you anything that's not going to be on that handout. You can, under certain circumstances, close the meeting, but only for very limited reasons. You can only close it to discuss a person's character, competence, or health, to discuss pending or imminent litigation, to discuss certain matters regarding acquisition or sale of a real property, deployment of security personnel and devices and systems, to discuss an investigation of alleged criminal conduct, and certain deliberations and decision-making involving the procurement process. I don't see any of those being done under the purview of this committee, but in case you do feel that you need to close the committee, those are your reasons for. If you close it, it must be done by 2/3 vote of the quorum that's present, except you can do a majority for other reasons. No vote is required to close a meeting of any other committees that aren't involved in this one. You may conduct an emergency meeting if it's less than 24 hours notice, if unforeseen circumstances arise that require you to meet and consider matters of an urgency or urgent nature. If you are conducting a virtual meeting, the department must also define an anchor location, which is a physical location from which the electronic meeting originates or the participants are connected. Generally, I would say that's the Cannon Health Building, which is where it looks like Melanie is administering this meeting from. The other thing that we have to do on the yearly training is give you the 2021 amendments. And these are amendments that were enacted by the legislature in the 2021 general session. Those amendments are that, and I'm going to read this because we have to be a little bit careful and make sure you've been advised of these. One of those is that the legislature modified the process of publishing public notice and public information on the public notice website. It created a new Utah Open Records Portal website and a Utah Open Data Portal website to serve as an additional grammar request point of access for anyone who is attempting to grab any records of this committee. Additionally, the legislature modified the provision to prohibit a vote in a closed meeting except to end the closed portion of the meeting. Any votes cannot be, so you cannot take a vote in a closed portion of a meeting. Also, the legislature modified the Open Meetings Public Act to include the anchor location that we just discussed. That is at the Cannon Building. And finally, the legislature amended the act to require a state body that is not a public body, which this one is, to post minutes and any public material to the state public notice website. There are penalties for not complying with the Open Meetings Act. And that is, as I mentioned earlier, is any final action taken in a meeting that is in violation of the Open and Public Meetings Act is voidable in court. It is a Class B misdemeanor to knowingly or intentionally violate the closed meeting provisions of the act, just in case you were tempted to say or think that you could close the meeting without going through very strictly the requirements of the closed meeting portion of the act. And that is the training. Any questions?
Stephanie, would you mind making a comment or two, since Dave was sort of our previous person we're familiar with. Early on, this is relatively new board and there's been a bit of turnover. Can you just make a comment about indemnification of board members for their as voluntary participants in a committee or a board such as this, where there are such basically strict rules that we at least know that in volunteering our time, and I may be speaking for the others as well, that there are some protections from being vulnerable personally or financially.
Yes, under the Governmental Immunities Act, volunteers for state boards, as long as they act within the purview of their appointment, are indemnified or covered by state risk management for any actions that are or decisions that arise out of this committee.
Thank you. I hope that gives some comfort to those and those who we care to bring on later in the history as we go forward. All right. Any other questions? Oh, sorry. Sure.
I can just say that that is why we have an AAG assigned to these various committees, especially with the volunteer boards, because we want to be able to help this committee avoid any deep waters that may get them into trouble. We try to do it gently, but that is one of our jobs, is to keep you safe from a legal standpoint.
Sure. And I want to, in my position, and I know Dr. Red, when he was chair, felt the same way. We want people, we bring people onto this board because of their expertise and their commitment to the public health. These are valuable assets that serve the public. And we want people to be able to speak their minds and not feel somehow muted or figuratively, and to share their thoughts openly. Transparency is our hallmark in this committee, and I'm hoping it is in others as well. And so we appreciate the fact that the state is increasingly valuing openness and transparency and sharing of information with the public, that things aren't being done behind closed doors or in secret. So I know that I think I do speak for the rest of the board members from my knowledge of them in lauding that. But I do also want to create as much comfort as I can as the board chair to bring in comments openly from our board members, since we cannot do this in confidence. This is going to be public. So thank you, Stephanie, for reinforcing that. Any other thoughts, comments before we let Stephanie go back to rooting out? Rooting out.
Want
I
to
was going to
say,
say rooting out evil.
please, if you have any questions, any legal questions at all, you can send them to Melanie. Since you're on the board, and you can, or anyone else, Rich, and they can get the legal, Dr. Woolsey, you can get the legal questions to ask. We are here to provide full legal support to the committee and the individuals on this committee. So we are here to provide answers that we can.
Thank you very much. Thoughts, questions for Stephanie? Hearing none, Stephanie, dismissed. Thank you so much. Really appreciate your help with this, and welcome to our group. Let's go back to approve the minutes. Obviously, we're not either adding or detracting an agenda matter. We're just shuffling a bit. I trust that everybody has now had a chance to review them.
Make a motion to approve.
Is there a second?
Second.
Okay. Any discussion? Hearing none. First, motion to approve and seconded. All in favor, just raise their hand. Do you see a total vote count there, Melanie? Registered everybody from the board? Okay. And you have Misty's approval as well. So it appears to be unanimous. Thank you. Well, now, Dr. Odell, would you put your bright shining face on the screen? There he is. It gives me extraordinary pleasure to introduce one of my colleagues, and I could go on and on, but I'm just going to summarize it by saying Dr. Dan Odell is a superstar. He's been with us at the University of Utah Department of Anesthesiology for many years now. He is moving rapidly up the academic ladder due to his achievements, both in clinical care, in his research efforts with us his educational efforts and his administrative capabilities. So he's really a jack of all trades in our department. He sees patients in the Pain Management Center, which is in Research Park, which is an outpatient center focusing mostly on chronic non-cancer pain care. He is a member of the faculty within the supportive oncology program at the Huntsman Cancer Institute, where he sees cancer patients, managing their complex and oftentimes intractable pain problems, and was one of the initial members of that faculty, along with Shane Brogan and Jill Sint. So Dan, you're welcome to complement that with any other comments you have. But his resume is robust, and I'm just very pleased, Dan, that you took the interest and are willing to take a deep dive into the subject matter of cancer pain, which sort of fits within the larger line item of chronic pain. That was one of the approved conditions under the legislative act. There's a separate line item for cancer itself, but I think that really, and there's another one for other adverse effects, such as nausea, vomiting related to chemotherapy. This talk, unless you want to go further broader, Dan, I've asked you to focus strictly on cancer pain in order to take a bit of a deeper dive than I did when I first reviewed comprehensively for this group and for our website, which is the information center, if you will, for both the professionals and the public who want to access information about the medical cannabis program, both clinical and some basic science and applicability issues. So Dan, what we're going to do, just to let you know, once you finish, is we'll have a question and answer period. We'll review your summary and comments. We may come back to you and ask you to clarify if there's any issues, so we understand better what you were able to glean from the literature. We will then take that and summarize this and add it to the chronic pain under the cancer section of our informational portal. So with no further ado, Dan, Dr. Dan Odell.
Well, thanks very much, Perry. Perry served as an excellent mentor, as I'm sure you all know, for me over the years here. And I relish in the opportunity to come and talk to everybody about a topic that I find fascinating and challenging and invigorating. So I'm going to go ahead and share my screen if I can. Just give me a second here to do so.
Got it, Dan. Looks good. Thank you.
Okay, let me go ahead and just start this up. Okay, looks like everybody can see that okay, I imagine. I also send these slides out. I don't know. I think they were sent out. That's what I was told. I have made just a couple of minor changes, but everything, the content should be there. And I think Perry gave a great introduction. I split my time doing a few different things. One of those, and probably the one that I'm most passionate about, is a clinic that is in the supportive oncology and survivorship group under that larger umbrella at Huntsman Cancer Hospital. We are specifically treating severe cancer-associated pain. We do all spectrums of that, whether it be medication-related or interventional procedures, intrathecal pain pumps. We have a great deal of expertise in other interventional procedures to, excuse me, kind of try to decrease the burden of opioid use if we can. So of course, this brings up the idea of cannabis. So what I wanted to start with is just a few very real scenarios that I encounter every day. And I want this to be an open forum. So please, I know it's a little awkward on Zoom, but feel free to interrupt. And if anybody else has experience in this arena, please let me know what your thoughts have been. So case number one is Mrs. Jones. She's a previously healthy 72-year-old female with pancreatic cancer. The patient is undergoing chemotherapy for treatment of her cancer, recently noted a significant increase in pain. She's currently taking extended release morphine 30 milligrams twice a day and intermittent use of oxycodone 5 to 10 milligrams every 4 hours as needed. She's had to escalate that use. She's now calling into clinic and saying, hey, my pain is just a lot worse. The oxycodone isn't helping as much as it used to. And by the way, my grandson was over the other day and he brought in some marijuana and offered it to me, and kind of wonder what your thoughts are related to marijuana and cancer pain. The second patient is Ms. Smith. She's a 36-year-old female with recently diagnosed stage 4 metastatic breast cancer. She has really horrific metastasis to most of the bones of her spine and her pelvis. This is very classic. She's married. She has 4 young children. She works out of her home as an accountant for a local law firm. Just a very busy, previously functional lady is the theme here. As a result of her pain, she's used various over-the-counter analgesics. She's trying to keep her mind as clear as possible so she can drive her kids around and do her occupation. She's tried many of the immediate release opioids, tramadol, hydrocodone, oxycodone, and hydromorphone, but she gets really bad side effects. Lots of constipation, nausea, vomiting, pruritus, drowsiness, the classic stuff. She's really frustrated with her decreasing function and just asks, what do I need to do? I just want to get my life back. What do you have available for me? Third patient is a 21-year-old male. He has a recent diagnosis of osteosarcoma. He's now undergoing chemo and radiation therapy. His pain is excruciating. You do note, obviously so, that he has a history of polysubstance abuse with needle track marks evident on his arms in your evaluation. He asks you to give him anything you've got, anything and everything. He says he's used a lot of marijuana in the past, and he's asking for prescription opioids by name. And so that is the scenario on him. So as you can see, pain management in cancer is extraordinarily challenging. And interestingly enough, it's vastly undertreated as well. The prevalence in pain is 80% in advanced cancer patients. Cancer survivorship population is expected to increase. It's just increasing as our cancer treatments themselves get better. We have an increasing degree of cancer survivorship. One thing that's notable and alarming is that while our cancer treatments are improving, our cancer pain treatments may not necessarily be doing so. We're largely limited by medications such as opioids or medications that were previously, supported for use in other spectrums, such as gabapentin and Lyrica, and tricyclic antidepressants are largely what we rely upon. And so as a result, cancer pain continues to be pretty largely untreated in general across not only the United States, but definitely across the rest of the world. So I'm not sure how many of you are familiar with this type of ladder or stepwise approach. I wanted to just frame this in terms of how we generally, as just part of the background here, how we generally approach cancer pain. You can see this is the World Health Organization approach to cancer pain. Just wanted to bring this in really quickly. So with that first rung of the ladder, their mild pain, we're trying to use non-opioids, adjuvant therapies. As we escalate up the ladder with more moderate and severe pain, then we're including weaker opioids. I consider those as also probably immediate release opioids is what we start with, and then we're escalating to stronger opioids, extended release versions of opioids. And then at the very top, you see their interventional treatments. This is where I and my colleagues disagree a little bit with this ladder, which is interventional treatments, and that should really be considered at any stage of this ladder. You don't need to wait until severe pain. So that's one thing that we're working to advocate for. But in any case, let's keep moving so we can get to the meat of this presentation. So the question really becomes, does cannabis have a role in cancer-related pain? And that's what we're really working hard to find out. This, just as a brief introduction, this is, you're all, I'm sure, familiar with this, the National Academy's report. Of course, they talked about, this is published back in early 2017, they talked about every possible application of cannabis. Pain specifically was under that umbrella as well. They didn't necessarily go into specifics related to cancer pain, but they did look at chronic pain, under which was cancer. So that was kind of the frame of this for quite some time. I'm not going to talk specifically about that report. but we're going to continue on some others. But I will just mention that their conclusion was this top line here. They did say there was conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults. So that was one of their conclusions. If you haven't specifically looked at where they drew that conclusion from, it was a study from Whiting back in 2016. I encourage you to go to look at that one study. It's a meta-analysis. It has its shortcomings, but the best that we had at the time. But anyway, go and see if you agree with their conclusion there. But I did want to get on to 3 main studies. So that's what I'm going to highlight today. Just keeping an eye on the time. We're just going to kind of blow through some of these. Again, interrupt me if there's questions or comments. These are somewhat complex studies, but I want to try to get through the meat of these and focus on the conclusions that were made. So the first of these is related to Sativex, which I don't know the audience specifically here, but I'm sure you're all familiar with. And so this was a series of, there were a total of 3 studies, and 2 of those studies were included in this first publication, and the third was published separately, and that's what I'm going to talk about next. So I wanted to start with this one. This was published in the British Journal of Pain back in 2017, kind of the first half of 2017. And so, like I said, this included 2 separate phase 3 double-blind randomized placebo-controlled trials that were multi-centered, obviously, all across Europe. The first one included the United States as well. I mention that because that actually becomes very relevant in just a moment here as we look at some of the results. Inclusion criteria were advanced cancer, an average NRS of greater than or equal to 4 or less than or equal to 8 at baseline. And they had to have what they called optimized opioid therapy. And when I first read that, I thought, well, what does that mean? And then they further defined that as they were at a limit of opioids to where any further escalation would bring on adverse effects, those ones that I kind of previously mentioned, or with further escalation, there was no perceived benefit. They didn't expect to have any further benefit after that point. There were specific exclusion criteria, which I didn't list here. After they reached a certain threshold of oral morphine equivalence that was greater than 500, they were excluded. People that had previously or were currently using a cannabis product were excluded. Those were some of the main ones. So specifically for study 1, and I just listed kind of the key points of study 1. In just a second, I'm going to show a little bit more of a complex flow sheet that was directly from the paper. But just to give you a background, 399 patients were included from 101 centers, and they were randomized to Sativex versus a placebo. And then they were self-titrated over an initial 2-week period. So they were, and this is important when we go from study 1 to study 2, this is the main difference, is that in study 1, they were randomized up front, and then they were given a 2-week treatment period. Excuse me, on study 1, they were not randomized until after they went through the self-titrated period. So I'll show you that in just a second. It'll make more sense. But anyway, they self-titrated the meds over a 2-week period. What that consisted of is over the course of 24 hours, they were given the option of how many sprays of Sativex they administered to themselves until they reached a positive effect or a tolerability issue. And then that was considered the dose that they were followed with on their 3-week treatment period, if that makes sense. For this study, the primary efficacy endpoint was % improvement in average daily NRS scores. So that's compared to study 2, where 206 patients were included from 65 centers. And keep in mind, this did not include the United States. All patients self-titrated Sativex over 2 weeks, and then they were randomized if they received greater than or equal to 15% improvement. They were randomized to Sativex or a placebo. And then following that, there was a 5-week treatment period. Primary efficacy endpoint in that case was the mean change in average daily NRS scores. So what I want you to do is just kind of take a second to stare at this. Sometimes it's worth just, not a picture is worth 1,000 words. So just look at this. This is study 1. And then in the next slide, I will go to study 2. You can see on the far left of the panel, that's when they were originally screened. They were then randomized. They had that 14-day titration period, depending on which arm they were placed in. They were then given the treatment for the following period, which we discussed. And then at the follow-up periods, they were asked the outcome measure questions. So I'll just leave that up for a few more seconds so you can kind of get an idea for it. And then moving on to study 2, excuse me, you can see here's the main difference, the screening on the left. Then they were all treated and titrated on Sativex, and then they were randomized. So that's the main difference. Let's see, other interesting things here. They're kind of comparing, if you look at the top of the panel, you can see it says Part A and Part B. They actually took outcomes, they measured outcomes at both of those different parts. So even when everybody was not randomized, they actually looked at some of the outcomes, and then Part B was after randomization. And then they, again, looked at the outcome measures at the follow-up visits. Let's see, so this is kind of the obligatory slide that just shows that both study 1, again, just take a second to stare at it. These are mostly demographic information showing that they're equal. Study 1 is the 2 left-hand columns, study 2 is the 3 right-hand columns. Take a second to look at that. I find some things pretty interesting. If you go down in study 1, you can see that the pain duration was similar between 1.7 and 2 years in duration. Average pain NRS score was similar, about 5.7, 5.8, which was similar across to study 2 as well. And then also look down, just keep in mind the daily opioid use. That's the bottom category. And then they break it up into the total as well as maintenance and breakthrough. And you can see that the mean morphine equivalence was anywhere between about 170 and 188, 190, and that was consistent across not only both groups but both studies as well. And that's I would say pretty common, where we get to, there's going to be some patients where they start to have opioid related side effects with a single hydrocodone. And there's going to be some people that have nothing until they're up to 800 oral morphine equivalents and they're still fine. But I would say on average, kind of just anecdotally, somewhere kind of approaching 200, it seems like we kind of have to make a decision one way or the other, like we got to do something else. I know we talk about the threshold of 90 OME based on the CDC recommendations. That's also a good landmark, but I think this is typically what we see, somewhere around 200 is where a lot of our patients end up. Yeah, Perry.
Dan, let me give you a chance to just catch a breath and maybe take a drink of water at the moment. The one thing that really stands out to me on this is that the so-called oral morphine equivalents, or the equivalents that folks are taking, really is about the same if you look at almost any study of either cancer or non-cancer patients in huge databases, millions and millions of patients. There's nothing particular that stands out along with this for people who have severe persistent pain. So that's point one. The other that's probably more important epidemiologically is that this, in terms of the mix of ethnicities, race, et cetera, is highly skewed towards whiter, I guess, Caucasian or Northern European folks. Now, this is a European study. We know that there's a lot of pharmacogenetic differences amongst ethnicities. And when you're talking about not only opioids, but now we're moving into cannabis, and Sativex, just a reminder, is a mixture of CBD and a 1-to-1 CBD and THC in the spray form, as Dr. Odell said. It's really very hard to make any generalized or conclusive statements in the face of this kind of very skewed data, except for how it affects maybe Northern European Caucasian individuals. Would you agree, Dan, with that?
Yes, sorry, I just muted myself for a moment. Yeah, I think you're absolutely right, and that's great perspective and putting that in context, I think, for sure. Perry and others, am I being
Pam,
presumptive?
I have another question. I'm Katie Carlson,
Yeah.
addiction psychiatrist. Just curious, I'm seeing the 200 milligram kind of significance. It's kind of where people seem to land with the chronic cancer pain. What's the significance of the 90 milligram morphine equivalent that you mentioned? You
That I
said
mentioned.
it's kind of a marker. From your perspective, what's the significance?
So that was an arbitrary number, and others can chime in on this as well. The CDC put out recommendations for opioid prescribing specifically for primary care physicians some years ago, and they kind of arbitrarily chose two thresholds, the first of which was 50 and the second of which was 90, indicating that after those thresholds is when perhaps more adverse side effects would start to arise. I personally, don't find those numbers particularly useful, especially in the cancer population. But where I do find it useful is when I'm helping a patient wean from opioids. I like to use those as like markers, goals of, let's first get you to 90, let's move past 90 and then 50. And I think it's reasonable for that, but that's why I mention it. Yeah. Perry and others, am I being presumptive about Sativex? Does everybody know what that drug is, or do we need to review that at all?
Dan,
Go
this
ahead
is-
and review it, Dan. We've got plenty of
Yeah.
time.
Okay, I'll just give a brief rundown on it. I wish I had a slide on it, but it's a category of medicine that's not currently approved for use in the United States. It's approved for many other countries and is actively being used specifically for MS-related issues. Lots of studies being done in that arena. It's basically a 1-to-1 oral mucosal spray, the 1-to-1 indicating a ratio of CBD to THC. So whereas so many of our other products are CBD heavy, it's a 50-50 mix. And the other interesting thing about it is the oral mucosal administration. So when I mentioned before, that's what these patients were able to do is actually spray that into their mouth and then escalate based on their needs. So that's what all of these first three studies are based on, is this oral mucosal spray that's a 1-to-1 ratio. Which is kind of interesting because many of the studies, including the Whiting study that I had mentioned earlier from 2016, one of the shortfalls of that study is, in my opinion, that the preparations or the mode of administration of the cannabis products were widely variable. I mean, majority was smoked, but here at least we have, a consistent mode and a mode of administration and medication. Does that kind of make sense? Anything else, Perry?
Well, I was only going to say that you talked about the variability, and it was huge. The number of sprays goes from a few to too many to count, and it becomes almost ridiculous in a number of these instances. And part of that is because of the pharmacodynamic responses. The other is that in the data, at least that I know that the company had acquired, and not a lot of this was published, but the variability in pharmacokinetics is extraordinary. How much is actually absorbed, and mucosa varies, the amount of salivation varies, the amount of the temperature in the oral mucosa. So even though oral transmucosal administration of lipophilic drugs is generally has been demonstrated, for instance, in oral transmucosal fentanyl, as being fairly consistent, but even so, pretty wide variability with drugs like the CBD and THC, each of which has different solubilities and characteristics. And again, these are big molecules, although they are more lipophilic than hydrophilic. The ability to cross the membranes is highly variable. And so it's hard to create generalized conclusions if you don't match PK with PD, which were not necessarily done in these studies. So sorry, Dan, I don't mean to take away your thunder, but following this from early on, that was a real issue that needed to be explained, I think.
No, I think you're right. And I think the transmucosal fentanyl is the perfect example where it studies have borne out that it really depends on how somebody sucks on a lollipop. You know, some people kind of just leave it in their mouth and just let it dissolve, and some people actively suck and swallow. And you know, the same could be said for administration of Sativex as well, I suppose. But yeah, it's by no means perfect, but at least we have a consistent medication in this study. And as you'll kind of see, you know, we're just still looking for higher quality studies for cannabis and pain. So, all right, so let's see. So I'm just going to go through some of these results here. Again, I kind of summarized them here. The tables we'll look at a little bit, but they're complex and kind of hard to understand. So this was some of the results that were noted in the paper, that the primary efficacy endpoint was not met in either of those studies. But interestingly, and this is what I brought up before, it was favorable for Sativex in United States patients that were less than 65 years of age, and that was not observed in the rest of the world. We'll get to that in a minute. One of the ideas for that, and I'll show this in the table, is that the US subgroup actually had higher pain and lower opioid use, which, if you don't believe me, I'll show you the numbers in a second, but that was borne out. There was improvement of patient function that was observed through quality of life questionnaires, and that's consistent throughout all three studies that we'll look at. But that did not translate to kind of their outcome measures as far as pain goes. And then similar safety profile that's been seen previously, and there was no evidence of abuse or misuse. This is one of those tables that I was noting was kind of complex. This is hard to understand. I don't know if we have a statistician on the line here, but suffice it to say, a positive score indicates favorability for the treatment of Sativex, and negative for no effect. So you can kind of see that here, and this is where they drew their conclusion from. This is kind of interesting. This is the adverse effects that you can see in the drug versus placebo. Just take a second to look at that. They were all somewhat similar, except for, you know, you can see somnolence was noted to be greater in Sativex, vomiting somewhat more. Kind of let you draw some conclusions from that. And then this is for study 2. That last one was for study 1. This one is for study 2. You can see this is where I was indicating that it's separated between part A. Remember, that's where it was the where all participants were using the drug. There was no placebo, and then they were separated into treatment and placebo. And you can see they're similar to what we had kind of noted before. This is specifically the U.S. arm of the study, or the U.S. patients. And what you can see here is the percent improvement. And this is specifically looking at the different ages. So you can see that at less than 65 years of age, there was greater improvement of pain with Sativex compared to placebo, and that's the opposite in ages greater than or equal to 65. Let me see if I have one more slide on the, okay. So this is what I wanted to kind of touch on. This is, again, just the demographics of the US population versus the ROW, that's the rest of the world. So you can see how those were kind of divided up. And take note specifically of the total opioid dose. Again, that's the third line down, 149 and 158 in the Sativex plus placebo, and then compared to 220 and 230. And then a greater percentage of US patients had previously used cannabis as compared to the rest of the world. So, you know, some of the conclusion that was drawn here, and we'll see in the next study that I'm gonna talk about, was the pain was greater. That's the other thing to note is the average pain was 6.2 and 6.4 compared to 5.5 in the rest of the world. The pain was greater, but the opioid dose was lower. And so the authors kind of discussed was there downregulation of the opioid receptors in the US population versus the rest of the world. And since we know there's crosstalk between opioid and cannabinoids, was the Sativex more effective as a result of that? So that was postulated and kind of discussed in the paper, and I find that pretty interesting. Any comments or opinions on that? Kind of interesting. So the conclusion, I just kept it simple here, just because I think that's why we're here, is just to kind of look at the overall conclusions that we can draw from this as far as how cannabis relates to cancer pain. Did not demonstrate superiority to placebo in reducing self-reported pain scores, which was the primary kind of outcome. But I will say that
just a question, just to
Yeah.
so help sort of people get a perspective. What percentage of the patients that you get referred for treatment are greater than 65 versus less than 65 in the cancer center?
I'd probably say it's pretty evenly split. Just because I feel like, the main, and I'm not saying that it's split as far as who gets cancer, because I definitely don't think that's the case. But some of the very most painful cancers come at a younger age. I mentioned the sarcomas. I often feel like the pancreatic cancers are usually more like in their late 50s to early 60s. But to me, it seems like it's mostly split, although there is a high number kind of after 50, kind of 55 and up. But I don't know. I feel like it's pretty split evenly. What do you think?
Well, the only statistic I know is that majority of cancers that solid tumors for sure are over in the older population. The more devastating cancers, for instance, as the cases you presented, the sarcomas, obviously, brain cancers in young people, Wilms tumors in younger people, breast cancer in younger women. These are the ones that we tend to remember because they're just devastating in the peak of life. But just from an epidemiological standpoint, the majority of cancer and cancer deaths occur after age 65. So I was and of course, the majority I don't know any more about the majority of people with experience using cannabis in the United States. It used to be younger than 65, but now with the baby boomers who grew up in the 60s and had a lot of exposure to cannabis, it may be more. So I just kind of get a sense of flavor of the kind of patients you deal with, and your thoughts about the conclusions with the who might be responsive at a younger age.
Yeah, and I think in the grand scheme of things, I think that's definitely true. And I think what I'm seeing is probably a skewed representation of the overall cancer population. Of course, younger people tend to, even with really severe, horrific cancer, seem to live longer and deal with pain longer. And so I think that's probably part of what I see as well. But yeah, I mean, absolutely. I think what you're saying is right on.
And Dan, are you going to come to, I don't want to presume, but at some point, if you could speak about, since the program is about cancer survivorship and there is greater survival, the number of people who are post-treatment, whether it's chemotherapy, radiation, or surgery, end up with chronic pain conditions, persistent pain conditions, and the ambiguity of calling this cancer pain versus chronic pain at that point in time.
Yeah, I think that's definitely worth a discussion. I don't specifically have a slide on it or anything like that, but that is definitely, I was just talking to one of our fellows yesterday about this. I think that's definitely something that we need to consider, is that, there's people with active cancer pain, like the woman I noted at the beginning with an active sarcoma growing into a part of her body, versus somebody who's in survivorship and now has treatment-related side effects like chemotherapy-induced peripheral neuropathy, which can be really horrific, and others. So, the studies that I looked at don't necessarily separate it out into those. Maybe the final one that we'll look at does a little bit, but otherwise, that's still, I think, a little bit vague, but definitely needs to be looked at. Does that answer the question? Okay. All right. Got the thumbs up. All right. So, I'm going to move to this one. This is it is a separate publication, but it's kind of, as you'll see, it's a very, very similar study, published separately, but kind of included in the series of these 3 studies that were performed. And so looking at this one, this is again a phase 3 double-blind randomized placebo-controlled trial. The inclusion criteria were very similar. Pain scores greater than or equal to 4, less than or equal to 8, despite optimal opioid therapy, which was similar to what I indicated before. 199 patients were randomized to nabixabols, which is the same class of drugs that we're discussing, compared to 198 to placebo. And then again, I'm going to show that flow diagram again, but they self-titrated study medications over 2 weeks, followed by a 3-week treatment period. So pretty similar study to the previous ones. The primary endpoint was the median % improvement in average pain scores in intention to treat population, and that's going to become important in a second to understand the difference between intention to treat and per protocol studies. But so here's, again, this is the flow diagram. And, it may seem a little bit redundant to include another study that seems to be very similar, but this is just what we have. Perry asked me to look at studies over the past, I think it said several years or 2 to 3 years. This is kind of what we have. And so I think there's room for improvement, but unfortunately, we're still waiting on more. So I think this is useful to look at. So you can see this is very similar to study number 1 of the last series that I talked about. Here's the demographics. We can see again, similar to what we looked at before. It's not much different there. The overall opioid dose is similar, again, kind of approaching 200. So I'll just continue to kind of move on here. I will note, just not totally to skip over this, if you look at the type of cancer pain, and we look at the top line there is neuropathic. Neuropathic pain in general terms, not just in cancer pain, neuropathic pain is extraordinarily hard to treat. It's extremely frustrating. Some of the worst pain syndromes that we know about are neuropathic pain related. And even with the best of what we have, we throw everything at it. And at some point, there's just nothing that you can do for neuropathic pain. So that's become of some interest. And a lot of the studies outside of cancer pain look specifically at neuropathic pain, because that's kind of considered the holy grail of sorts. Is if we can get a better handle on that, then we'll make a lot of progress. So Perry may want to comment on that later, but that's, I think, how we all kind of feel about it. Hold on, I got to move this box out of the way so I can see all of this. Okay. So looking at some of the results from this one are kind of interesting. The median improvement of average pain from baseline in nabiximols versus placebos was 10.7% versus 4.5% in intention to treat population. And then if you look at the same measure in the per protocol population, it went from 15.5% to 6.3% with a p-value of 0.0378. So that's actually something I had to review. Again, I don't know if there's a statistician on here that can explain this a little bit better, but the intention to treat versus the per protocol basically comes down to the intention to treat population is everybody that was initially randomized was included in the outcome measures, even if they dropped out of the study or for whatever reason, they were still included in the outcome or in the measure, whereas the per protocol is considered to be optimal for the drug itself or for the treatment itself, as far as if people were dropped out of the study or were taken out of the study after randomization, then they were removed from the outcome measure. Does anybody have a smarter way of saying that? Or does that kind of make sense to everybody? Maybe everybody already knows.
It does, and it's very important, I think, for the board, for members and people listening who don't have a lot of experience in clinical trials or the way regulatory agencies like the FDA would look at pivotal trials. I can't remember, was it Disraeli who said there's liars, damn liars, and statisticians or something like that, that you can use statistics to demonstrate almost anything you want to. And so you have to have sort of an objective, unifying approach so that statistics cannot be misused to misinterpret. And if you bring a broad group of individuals into a clinical trial, you do what's called powering, right? You make it a large enough sample so that you can tell if there's a meaningful difference, both statistically, but also clinically, between people who have a fairly robust placebo response and those responses that might be specific to the drug in question. But if you don't separate out and recognize that there are individuals who genetically or dispositionally, for environmental or other reasons, social reasons, or whoever knows, but mostly genetic, may be responsive to one type of a drug or another that is very specific to that drug, that information may get actually washed out if you have a large, broad population. And that's why I thought it's very important when you look at different ethnicities, if you're trying to create broad conclusions or general conclusions, which is what science is about, when you don't have an adequate baseline or predicate for that, things can get very confusing. So intention to treat versus by protocol is very important when you're weighing and determining whether, not that if you approve a drug, but how to determine as a clinician, if you're going to prescribe this and you say, and you don't get effects, to blame it on the drug, or is it the fact that the drug and the relationship between the drug and that particular individual, because we all practice N of one, we don't practice population. That's not the way medicine is practiced. So to sort of summarize, we as clinicians, whether it's recommending cannabis and high THC, low CBD, intermediate, or otherwise, have to understand that there's going to be a placebo effect, and unless you understand how powerful that may be in an individual or population, but there also may be specificity of effect, which may be very difficult to cull from population statistics or studies like this, versus why an individual may be very enthusiastic or very negative about their experience with that particular drug or drug product. So in other words, it's extraordinarily more complex than any clinical trial will ever be able to demonstrate, unless you have very large, broad registration trials, which is increasingly becoming acceptable, but never was as the gold standard for drug approval. So I'm trying to give a 5-hour seminar in 5 minutes, but Dan, you really do bring up critically important points, and I appreciate the fact that you're trying to make some distinctions there.
Well, and I think it has some relevance to this study, because as you can see, the per protocol based on the p-value is actually significant. But on the intention to treat population, which was their primary outcome measure, it is not. So I think it's particularly important in this study. And it's a little confusing if you go back and read this study. It's a little bit fuzzy. The way that they kind of discuss it, sometimes you're not sure which of those two they're talking about. So I think it's important to note that specifically in this study. Now, they did notice, again, compared as similar to the last one that I talked about, there was a statistically significant favorability towards Sativex or the nabiximols in 2 of the 3 quality of life measures at week 3, and all 3 of them at week 5. So that's something to keep in mind. And the same, the same result was found in US populations as well. This is just more of that. So maybe I should have pulled this up while we were discussing this intention to treat versus per protocol. That's what you can see on the bottom line there is the ITT and the PP. And then you can see, let me move my thing again so I can see the rest of this. Yeah, so you can see there all patients versus the United States versus the rest of the world, and how those kind of compared across the study. Let's see, just in interest of time, I'm going to keep moving here. This is similar. I want to get onto this last study. I will bring up the conclusions of this study. Again, nabiximols is not superior to placebo on the primary efficacy endpoint. They were superior on multiple secondary endpoints, which were those quality of life measures. And then this last bullet point that I put here indicating that there may be greater utility in patients with relatively lower opioid dose. They may have more efficacy. That's drawn from that US population. And this does happen in people that have lower opioid tolerances. Maybe that's a good population to look at because they have just by nature lower opioid dose. So final study that I'm going to talk about here. Oops, sorry, I'm going to go back there for a second. This is a study out of Israel. It's vastly different than the previous three that we've talked about. And so I'll just kind of go through this one. This is a prospective study of almost 4,000 patients from Israel. There were 16 strains of THC and CBD concentrations that were administered. And this was either in oil form or in what they called inflorescence, which included flowers, capsules, or cigarettes. And then they had pretty simple follow-up. It was a 1 month and 6 months. And this was generally done over the telephone. And they would just ask the question, how would you rate the general effect of cannabis on your condition? With the primary efficacy outcome being, and this is again, kind of hard to, what conclusions can we draw from this? But their efficacy outcome was at least moderate or significant improvement of a patient's condition at 6 months. So I didn't put it on here, but when they asked that question, how would you rate the general effect of cannabis on your condition? The study participants were told to respond with, significant, moderately significant, and then all the way down to not significant or even harmful. And then they also used the numerical rating scale as a measure for pain. So this is some of the results of this study. At the 1 month follow-up, I just kind of pulled these from the vast number of results that they had. There were, and I'll show you this in a second, there's a little graph, but of 2,082 active users that responded, 1,380 or 66.3% reported significant improvement, 19.5% moderate improvement, while 8.3% experienced some side effects. And then what they considered to be a success or favorable outcome were a combination of those two. So a significant or moderate improvement was considered to be a favorable outcome for the use of cannabis. You can see the numbers for the 6 month follow-up. There were far fewer that responded, but 50.8% reported significant improvement and 45.1% moderate or slight improvement. And then among patients who reported pain between 8 and 10 at the onset of treatment, which was 52.9%, only 4.6% responded similar intensity at 6 months with a p-value of 0.001. So that's kind of interesting.
Can you repeat the pain rating scale that was used?
It was the numerical rating scale. So that was the 0 to 10 scale. Is that what you're asking?
Something else. Thank you.
Yep. Other results that are somewhat relevant, 18.7 reported good quality of life at the onset of treatment. And that went all the way up to 69.5% reported good quality of life at 6 months. Opioid use at 6 months, 36% discontinued completely, 9.9% had a decreased dose, while 51.1% maintained their dose. And then again, at the 6 month mark, 30% of patients reported at least one side effect. So I just bring this study up because it's different. It's much different than the previous study that I kind of mentioned. You can see the demographics here. Keep in mind the different types of malignancies. This is exactly what we've been talking about. The ones that we see the most in my clinic are those top 5 to 10. Breast cancer, we see a lot of pancreatic cancer. Multiple myeloma, we see a lot because of obviously the osseous involvement of the spine. And then kind of going on down here, which you can see, that's all very classic, I think. This is kind of interesting to stare at for a moment. X-axis is the pain intensity, and then the y-axis is the number of patients who experience that intensity. The blue being before the treatment with cannabis and the orange being after 6 months of treatment. So you can see how this kind of distribution changes over the course of treatment. With more orange towards the left side of the graph, I guess is what I'm saying. So that's something to keep in mind. This is the concurrent use of other medications. Opioids is on the top line. Anxiolytics is the third line down. You can see there, that's what they indicated before, that 36% said at 6 months they stopped opioids. And then you can see their anxiolytics, 23.8% stopped. This is looking at the success rate based on different subgroup analyses. This little box on the side is tiny, but it's just subgroup analysis of treatment success. So you can see based on gender, top left, if they've had previous experience with cannabis. Yes is in the dark gray, no is in the light gray, and you can see the success rate. Age is in the bottom left. And then another interesting one that they looked at is concerns about cannabis treatment and comparing to their success rate. You have to keep in mind that the dark gray in this case is no concerns about cannabis treatment prior, compared to yes on the light gray. So just kind of some interesting things that they looked at in cancer patients, which I found, just interesting. And then based on cancer type, they looked at that specifically. Kind of move on from there. So this is kind of what I'm getting into now, is overall conclusions for all the studies. And then there's also a review article. The review article was published in 2020, kind of in the latter half. So that's another paper that I can send out, but it's a review article based on, I focus specifically on clinical studies today. There's preclinical studies that are also available that actually are favorable for the use of cannabis. But then the question is, how well does that translate into the actual clinical setting? So that's an interesting article to look at. Some of the conclusions that were drawn both from the studies that I looked at today and then from that review article is some of the notable limitations of these that I specifically talked about today, and others are that it's still a small sample size, very high attrition rate. Obviously, the cancer population, that's always going to be the case. And then some unclear randomization and blinding procedures that were used. This is what I mentioned before, is how much can we translate this data from preclinical to clinical practice is somewhat questionable. Obviously, we need larger, more robust clinical studies that are in the United States, absolutely are largely limited by our current regulations. This is what Perry was mentioning before, that the survivorship population is going to continue to grow with the ongoing pressure to decrease the use of opioids. So this is the name of the game for us right now. This is one of the most challenging things that we experience is, it's not like suddenly patients go from active cancer to survivorship. There's very much of a gray area there. And when do we make the transition to 200 or morphine equivalents to trying to get to 0 and supplementing with other treatments? That's a major challenge and of major interest to all of us that are in this field. Because as of right now, this is the last bullet point, active cancer population remains very, very much reliant on opioids. Kind of what I see as being the thing that we're all seeking, again, kind of the holy grail is, can we find ways of treating cancer-related pain, even end-of-life pain, with something other than opioids, sedative hypnotics, so that when people do get to this point, their quality of life doesn't suffer. They can still have a reasonable conversation with their family members. This is a completely separate talk, but this is where we get into intrathecal therapies. And that's what I'm really advocating for, is whatever it is. And this is kind of my line to patients is, who am I to say, if there's something that can be used for pain, even kind of theoretically, who am I to stand in the way of that? I don't currently personally prescribe cannabis, even in my cancer population, as I'm waiting for kind of more robust studies, but some of them have it from other sources, and we kind of just work on that together with the prescription of everything else that we do.
Dan, we're going to now, thank you, open this up to discussion. I'd like to just ask a couple of questions, just maybe fill in a few holes for people who don't know fully sort of what you do day to day. But a couple of questions that come to mind is, number one, there is a skewed population. The patients get referred to the pain treatment arm of the SOS program at Huntsman. These are the difficult patients. These are the ones the oncologists feel they need extra help in. So there's a bit of a skew there. So one question is, of those patients, what % are you treating, just adjusting medications, versus are amenable to interventional therapies, which may be more definitive. And by way of example, pancreatic cancer that may be highly responsible has a visceral cancer pain problem that may be highly amenable to neurolytic celiac plexus block versus intrathecal therapies versus intravenous lidocaine or ketamine for neuropathic pain and so forth. So can you give us sort of a general sense, given the skew of the population, how much room there is for truly a new advance in the field where nothing is really helpful, and of those, has cannabis in your mind in one form or another really met that need in any way, shape, or form?
Yeah, so in answer to the first part of the question, we specifically get referrals for interventional procedures. So I would say in 100% of patients, we are considering an interventional procedure. And it's all of those that you noted. And I'm happy to talk about those either off this meeting or at a different time. But those are very, very effective. We do them safely. We're very cognizant of the safety profile behind these, and we have a very good safety profile with all of these. The other one to keep in mind is radiation therapy, which is a great way of controlling pain without medications. But definitely all of our patients, 100% are considered for interventional treatments. Unfortunately, as a result of some competing interest with other cancer treatments, we're not always able to. Many of these patients are on anticoagulants. Some of them have contraindications to specific interventional treatments based on their chemotherapy regimen, concurrent radiation treatments. But I would say in general, of the people we see, greater than 50% undergo some type of interventional procedure as well as kind of aggressive medication optimization, I guess I should say. And I'm just saying this anecdotally in response to the second part of Perry's question. I have not personally seen that cannabis is kind of the silver bullet that kind of makes all of the difference. Where if somebody comes in and on the first meeting that I see them, they're in a horrible place and they come back having started cannabis and they're completely improved. I have seen it helpful as an adjunct, and I have seen it improve pain to some degree, and some of the adverse side effects related to chemotherapy, some that were mentioned here. So I do think that there is potentially a role for it, but it hasn't seemed to be consistent across the board of all patients that I see.
Thank you, Dan. And maybe let's use the raised hand function, starting with board members for clarification or questions or comments.
I see a raised hand.
I just can't find my raised hand.
Look under, it says it under reactions.
Oh, okay.
Katie. So Dr. Viner has his hand raised, but let's start with board members first. Katie, just go ahead and ask your question.
Okay,
Don't
I
worry.
just found it. Thanks, Perry. Just a question, and you might have said this earlier. In the studies on Sativex, the studies, there were 2 of them. Did you detox these patients before I missed exactly, how did they go from about 200 morphine equivalents of opioids to your study? I missed that.
So that was maintained. So nothing was done specifically to their opioid dose. There were exclusion criteria based on, a higher opioid dose. So that was where it got into like over 500. Then they were excluded from the study. But the opioids at the beginning of the study were not necessarily changed. It was just looked at as a secondary finding as far as their initial dose versus if that changed at all.
Okay, thank you for clarifying that. I find it, very, for me, from an addiction standpoint, it's very interesting because, I think when patients are able to tolerate even about 100 morphine equivalents, and then moving up from there, I know that I'm less familiar with this, but there's a lot of evidence that look, or a lot of studies that look at this from a physiologic standpoint, but from a behavior standpoint, the intertwining of the behavioral or the emotional and spiritual pain with the kind of physiologic and other etiologies of chronic pain, when they're so intricately connected. When someone is they're adjusted to that level of morphine, that amount of morphine, that I just wonder, when you're looking at, or when these studies are looking at THC or CBD and the impact on chronic pain, how those populations might respond differently. Those populations on lower doses may have more of a separation between the emotional, spiritual pain and I'll call it physiologic pain, for lack of a better word, compared to the population that really doesn't have that, either through all kinds of reasons, previous depression, anxiety, trauma, all those things that just impact someone's ability to recover from any chronic pain condition, or to live with it, in a way that's not filled with suffering. So I find it interesting that distinction between the population that's on a lower dose of opioids or have a lower tolerance of opioids versus a higher tolerance. I would just be really curious to look more closely at that.
Yeah, I think we all would be, and I agree. It's a interesting finding, and you have very astutely picked up on one of the greatest challenges in chronic pain management, and that is there is so much else going on in a patient's overall presentation other than just, to put it simply, like their pain number, right? And Barry can speak to this to much greater depth, and I mean he helped build this house of multidisciplinary pain management. I mean, to put it kind of simply, we talk about there's differing levels of copamine, where patients are going to have a different ability to deal with these things, and it's going to vary based on their current situation in life, and that's obviously no amount of any one of these medications is going to alter that. So that's why whenever possible, we do combine our management strategies with a psychologist and oftentimes a physical therapist to try as often as we can to modify all of those.
Yeah, not surprisingly, Katie, you did put your finger on it. And, we are, not to polish our halos too much here, we are one of the few remaining interdisciplinary pain programs in the country. And the Huntsman program that Dan is part of brought that philosophy over, along with the oncology group and the palliative care group, Dr. Beck, who oversees that, to make this a biopsychosocial spiritual model. And so having functional restoration, psychological support, social work, chaplaincy, and so forth is all part and parcel of, especially in the cancer center, since morbidity, mortality blends and is more accelerated because of the risks of death with cancer. So it is extremely complex and probably the major limiting factor in almost any clinical trial involving analgesics, and even experimental pain, because people's cultural background, the context, and expectations and beliefs. So for this, so interesting what Dan brought out was that for people who believe that cannabis is going to be helpful, guess what? It turns out to be. For people who don't believe it's going to be very helpful, guess what? Turns out it's not as helpful. So the brain is highly integrated. It used to be taught when back in the old days, the dinosaur days, back when I was that the old Cartesian dyad, there's body and mind. Well, we know that that's nonsense. That almost every part of the brain integrates the experience that is pain. Nociception, neuropathic pain, we're highly limited. We have the word pain, but it covers a spectrum of types of suffering. So not to draw it too broadly, but you've put your finger on it. Let's get to Dr. Red, and then we've got others who have questions. And Dan, unless do you have a fixed stop that you've got to get running here?
I got about 15 minutes left if that works. I don't know if that works into your schedule, but I got about, I
Great.
do have a thing in about 15 minutes.
Great. Well, let's go to Dr. Red.
Hey, thanks for your presentation, Dr. Daly. I got cut out because we have about 6 inches of really wet snow that's breaking all the trees and knocking down power lines and all sorts of stuff up here in Logan.
I heard about that.
So anyway, some of the things I've kind of noticed over the years working with people with cancer pain and other forms of chronic pain with medical cannabis is that a number of them will tell me things that are similar to the things that were outlined in some of these studies you talked about. But one of the things I think is interesting is several of them have mentioned that it didn't make that much difference in the actual pain level, but it helped me, it's a quote, they helped me not be so focused on the pain or be distracted from it. Helped me to be more distracted from the pain and not be quite so focused on the pain. I just wondered if you have any comments on that. I find it interesting that, and these people are just people that, that know I'm involved in this process, and just, sometimes they're my patients, sometimes other people just tell me, oh yeah, I've used it. It didn't make much difference in the pain, but it made me help me not be so focused and nervous or anxious about the pain and not worry about it so much.
Yeah, I 100% agree. I found the same thing. And sometimes they just say, like I say, well, does it help with the pain? And they say, no, it doesn't help with the pain, but it helps with the, and then it's just ... And they're like, I don't know. It just helps. So I do find that interesting. And then the question becomes, well, in someone with advanced cancer, then does it matter, if the pain number goes from an 8 to a 4, or does it matter that their quality of life is improved, or that they just feel better? And that I think is a conversation that's much larger than this. But the ones that have said that don't seem to care. I feel better. So,
and that's kind of, obviously this is anecdotal, just reports from people. Yeah. And I've had some patients tell me that they didn't like it at all, didn't help them a bit, just like, the study results show that too. There's some patients that are not going to benefit from it. And I think some of the attrition numbers are probably because patients either passed on or went into a different state of care. And some of them probably quit because it didn't help them that much. And so my experience with this is that everybody's a little different, and some people really seem to benefit in some ways and other people don't. But I just thank you so much for your presentation. It's really good to have somebody who has a lot of expertise in this area present, along with Perry and other people. It's just really good to have you come and help us out. Thank you very much.
Yeah, thank you. I think that's an important piece to remember. I'm glad you brought that up.
And that's what, it's worth mentioning and reminding everyone that we've had synthetic THC by prescription, available by prescription, pharmaceutical grade, in Marinol, Dronabinol, which basically it's THC in pharmaceutical form for decades. And early on, going back to the 1980s, in trying to address some of these difficult cancer pain problems, I would avidly try and titrate up pharmaceutical grade THC. CBD was not available. We're going back quite some time. And it was rarely successful. Occasionally people would tolerate it for chemotherapy-induced nausea and vomiting, which was one of the indications in HIV patients for inanition and for appetite stimulation. But unfortunately, it was titrated up more than 5 to 10 milligrams of pharmaceutical THC without any of the other myriad, either cannabinoids, terpenes, flavonoids, many other ingredients in cannabis, no less CBD. The ability for these patients it was one of the few drugs that they rejected very early on, especially older patients. Dysphoria, anxiety, hallucinations, paranoia, agitation, they just didn't like THC. So now we've gone past that because we've, I think, grown to accept, and I think Dr. Viner may be able to speak to this a bit when we get to him in a moment, is that there is this so-called entourage effect, which is really just interactions amongst different active pharmaceutical agents at receptor sites may mitigate some of these. But to your point, Ed, even with all the perceptual issues and the anticipatory issues and so forth, pharmacologically, there are adverse effects that just break through. And in opioids, constipation turns not to be a spiritual or a social issue. When your bowels don't move, your bowels don't move. And we understand pharmacologically why that happens. And we actively work to preemptively prevent that from occurring. But anyway, let's go on. I think Mark Viner and then Deanna, you were after Mark. And Mark, introduce yourself briefly to Dr. Odell as a sort of member of the public out there who's a physician.
Hi, Dr. Odell. I'm a psychiatrist in Nevada, but I had a couple quick questions. You mentioned the crosstalk, and I have practical issues when someone's on opiates for cancer pain, like how to introduce the cannabis. Because if you try to go from someone who's on moderate dose of opiates and introduce like a Rick Simpson oil or a strong full extract concentrate, that's actually kind of dangerous because there's synergy between the two. But the cannabis receptors, immune receptor, there's synergy. And I've had patients get really bad side effects just throwing in, it's tempting, like instead of using the fentanyl lollipop to go straight to the concentrate. But I find that that's not, the concentrate seems to be better when they're on a lower dose of opiates. Like you were saying, you bring them down, and then you can maybe introduce the concentrate. But I would be really cautious. There's studies that show CBD, heavy weighted, will raise the methadone level 2 to 3 times in a cancer patient being treated with for cancer. So those are in the literature. So I'm really cautious. I wish they could vaporize it to try it first, or maybe go try a gummy or a capsule. But I'm very cautious having them jump to concentrate because it's tempting, because it's like the fentanyl lollipop. And then my other question is, with today's chemotherapy, up to 50% is now immunotherapy, have I been reading correctly, or qualified for immunotherapy. So to mix something like Opdivo, Yervoy, and heavy CBD concentrate, I find that's dangerous, probably because of the immunosuppression that's occurring. They just don't mix well. I think we need to address, at some point, not today, the cannabinoids and immunotherapies being used for cancer, because I think you need to decrease or discontinue the cannabinoids while they're getting double checkpoint inhibitor, double checkpoint inhibitor therapy. I wonder if you've had any experience with that, anything.
Well, I think you bring up a good point, that there exists a lot of other medications or other treatments that we don't necessarily know. We don't know the degree to which they interact. I mean, even some of these newer immunotherapies, we don't even totally understand how they interact with some of even the more common medications, including like the opioids. So I guess what I can speak to is, in general terms, when that's the case, I have a very open dialogue with the oncologist. I sometimes bring in a pharmacist who's well-versed in these therapies, and start low and go slow, right? If we feel like it's really needed. I think the same can be said for cannabis, although I don't know specifically, any dose modulation related to it that we know of, but it kind of just uses the same principles that we all know about. Let's see, I think you're still on mute there, Perry.
Pardon me, Dina or Deanna. I'm sorry, I forgot how you pronounce your name, but please.
I prefer April, but thank you.
Oh, April. Okay, makes it easy.
First of all, thank you very much, Dr. Odell. I had the pleasure of working for Huntsman for many, many, many years before I opened up Terra Health. I worked with case management and worked really closely with the SOS team. One thing that I really appreciated about the SOS team was it was a multifaceted approach. They really looked at where the patient was today versus, the trauma maybe they had experienced, both from the medical side of procedures as well as where they might be looking to go moving forward. One thing I feel, and I would like to know what others' experiences are by way of the plant, is one thing I found very clearly in SOS and the case management group was there were times when we felt we were called too late, meaning we came in to help the families and they had been through, 5 years of 3 years, 2 years of just heavy medical interaction without therapy, without wellness resources, yoga, even conversations and meditation, kind of some of these alternative approaches. Addiction was a big thing. We had given them so many pharmaceuticals to deal with the medical procedures, but as they hit to that more, they're going into remission, they're going into end of life therapies. Their addiction was still a big conversation, and a lot of these folks were moved onto pain clinics, sometimes because they're no longer needing to see the oncologist. What I would hope to see, and what I want to know what others maybe have experienced is, in the studies, what I saw was it looked like an early approach with cannabis with a long-term over 6 months seemed to be pretty effective for most individuals in this study. So if they got it early, they had a chance to kind of adjust, and it was used more of a alternative therapy versus an injection of we're going to shrink a tumor, we're going to do some of these other things. What has been your experience for those folks? Because I think culturally, you have individuals who approach things holistically, alternatively, very differently in medicine. What has been your guys' experience with those who see it early on, they're utilizing it secondary to the treatments that they're having with their doctor, versus when the case management teams come in, the SOS teams come in, and the family's end of life, they're now having these different conversations of, we're not fighting to stay alive at this point, we're now transitioning into end of life care.
Yeah, I'm already unmuted, so I guess I'll just kind of comment first. That I don't think that at this point, I don't think we know always who is using cannabis and who isn't at any stage of their treatment. Things have changed so dramatically over the past 2 years that we just by nature of our clinic, we pretty much get random urine drug screens on everybody that we see for the first time. And I would say almost it seems like the majority have marijuana in their urine now, regardless of at what stage we're kind of coming in on this. Sometimes just based on the referral pattern, we actually see patients before they even see their oncologist. Like you kind of indicated, sometimes it's very, very late in the game, it's as they're basically preparing for hospice. But I think part of what's hard to answer that question is not everybody is getting prescription marijuana, and some people have been using it and they're not reporting it, and they don't include it in their list of medications. So it's hard to even know, when I see a patient, are they even on marijuana or not? And some people still feel very hesitant to answer that question to a doctor. And so I think that's a little bit hard to know what that pattern's looking at. But I would say kind of my own experience has been people are using it earlier. People are turning to it as an alternative earlier. Yeah.
Could I just
Well,
make a quick-
it's time to hey, I think we have to let Dr. Odell go. Sorry, Ed.
It's okay.
And we've got a bit more business to do before our time is done. Now, the process here, Dr. Odell, is that we generally take the conclusions from the evidence-based presentation, because that's what our board job is to take the most recent evidence in authoritative or published trials that are IRB approved, whether within the United States or extra US, and to fold that information into our publicly available information in our through the web portal. So Dan, I'll communicate with you independently and determine whether you want to do that little bit of work or I'll just do it for you. I think it's actually sadly it's easy because it doesn't seem that much has changed. And there probably is not much to change in the chronic pain section that we have, but I can speak with you offline. But let's let you go. Let's give a round of applause to Dr. O'Dell. Great appreciation, and I'll see you in clinic, Dan.
Sounds good. Thanks, everybody. Thanks for having me.
So thanks, and you're so very welcome. Thank you. And let's the next order of business is to look at we've distributed the suppository little summary. Remember, Dr. Wilcox presented that, summarized that into a format with that we've adopted in our public information, and that has been distributed. And it's time for a vote to accept that as written, or if there's some late breaking thoughts, we can entertain those. But I think this has been circulated now for the last several weeks, and comments have been made. We've incorporated those, sent them back out. So I think Melanie's done all that work alongside with myself and other board members. So may I have a motion to approve?
So made. Dr. Z.
Dr. Zender, thank you. Is there a second?
Sorry, Dr. Fine, we're talking about the suppository document?
Yes.
Okay. I had just a couple comments of things we could consider adding to the document. I was wondering at the start where it's talking about potential indications for the rectal and/or vaginal administration, if we wanted to consider adding a desire for like localized effects.
No, Lauren, let me remind you, this is for systemic treatment, not for localized. This is
oh, I
independent of
see. That's
localized.
why you.
Yeah, that was the intention of the presentation, and the whole localized treatment issue is a whole separate one. So this is about systemic therapy.
I see. Thank you.
Okay.
Then the other thing I was wondering if we wanted to comment on was the part about the pharmacokinetics pulling from that one study. If we wanted to talk about just something more specifically about the overall systemic exposure, like talking about the comparative AUC that they talk about in the study.
You have a specific point that you would add or detract from the way it's currently constructed?
Well, I thought it just talked more about kind of the peak concentration and the time of onset of that, but I thought we could add a comment about the overall, there was like a greater than twofold higher overall systemic exposure with the rectal administration compared to the oral in that study.
And that's in that particular study? Okay. Any other thoughts about that particular point from anyone? Okay, so given a modification, an amendment or a modification in it that will suggest that there may be higher overall systemic absorption, that's largely because of decreased first pass metabolism, usually, correct, Lauren? I mean, that's really the issue. So we'll look at that and clarify that point. And with that amendment or addendum, any other thoughts, considerations? Okay, with that given, is there a second to approve?
I second.
Okay, Dr. Carlson seconds. Let's say a show of hands right in front of your screen by board members. 1, 2, 3, 4. Okay, and then Misty's got hers, so it has now been approved. Our next bit of business is there's a question whether am I correct, Melanie, whether the Alzheimer's went through formal approval. I thought we did,
I
but
looked back I went back and listened. There's not a formal, everybody raise their hand and approve it.
okay. So
If
we
we can
need
just do
to,
that.
yeah, this has been through multiple reviews, both by the presenter, myself, all board members have had multiple editions of this. And I thought we had actually gone through a formal approval 2 months ago. I guess we just missed it. I apologize administratively. So may I hear a motion to approve for the Alzheimer's disease document? If you can fetch back in your memories. We had robust discussion. Nobody had any additional comments. So now it's just a formality that we need to make so that we can note that in the portal.
I move to approve it.
Okay, so moved. Second. Okay, all in favor? Show of hands. And again, we do have Misty's approval. Okay, so that has been formally approved. Last order of business now with in the last 5 minutes, and then we'll get to public comments, although we've already had some robust discussion. Rich, do you just want to summarize very quickly the process for the annual report, where we stand, the fact that on the 17th of November, we'll be giving a live presentation summarizing the work we've done this year, which has really been quite extraordinary. Hats off to all of you. So Rich, why don't you take it away?
Yes, thanks, Dr. Fine. So we have a version of the report that has all of the updates and changes to it. The only thing that we need to add are the decisions that were made today. And so we'll make sure to reflect those new changes to that version. And then Melanie will make those updates. And then we'll be able to have Dr. Fine represent the board. We haven't received a formal invitation from the Health and Human Services Interim Committee yet, but we do expect that to come. And when that comes, we'll be able to know exactly the time of that presentation. Let me get for the group really quick, just so you can put it on your calendars. I'm going to just a second here. I'm just going to go to my own calendars. I confirm the date of that. It was, I know it's obviously in November, and I'm just having to log in really quick to my computer. If anybody has that offhand, would you give it?
Yeah, it is the 17th, starting at 8:30 in the morning at the Capitol.
Great. So Dr. Fine will likely be invited to present at that meeting, and we'll share with the group the time and everything of that. So that'll be the oral presentation, and you're welcome to join that virtually. And
please do.
And we're excited to have that presentation of our of the board chair. That'll be a good opportunity also for the board chair to answer any questions that the committee may have about the work that the Cannabis Product Board has been doing for the past year. And yeah, so that gives you an update on the annual report and the plan to orally present a summary of those main points from the annual report that'll be done in November by Dr. Fine.
Thanks, and you'll all get a copy of both the final report as well as the slide presentation that will summarize key points. And it's also important to mention that the Compassionate Use Board will also likely be given a presentation, as will Rich Oborn, a full report of the operations and so forth around the Cannabis Product Board. The Center for Medical Cannabis. I do want to, I know we're going to go over a couple minutes, perhaps if people have comments, but I really appreciate Dr. Odell's entertaining, and I know I stole a bunch of his time because I just think there was a lot of other context that was important to bring to the discussion. Any other thoughts from the public, which we really appreciate your attending and you're hanging in there with us. loyal members of the public. Well, seeing none, our next scheduled meeting would be November. It turns out that I have a great reason to defer until December, and that's because my youngest daughter is getting married, and I'll be involved in all of that. So I'm going to. So we don't have an obligation to any numbers of meetings a year, so it really doesn't require a vote. It's simply at the discretion of. And we've covered so many of the pressing matters on this meeting. Our December meeting, so there will not be a meeting in November. In December, we will have been past the annual report. We'll probably spend a little time reviewing that, and then we'll be considering basically our strategic plan or path forward for calendar year 2022, if you can believe it. So I'll reach out. I plan on reaching out to each of you individually on the board just to sort of get a sense of your priorities, thoughts. But by obligation and for openness, any deliberations will be in public. And so what I just want to do is create an agenda around some of your thoughts. And if anybody else wants to submit any ideas, completely open. But we'll set our priorities for 2022. We'll likely be delving and doing a deeper dive into some of the areas that we have yet to cover, such as cancer and perhaps HIV. And maybe by that time we'll have additional help to dig deep into the available literature for the next few years, if there is anything new or different. And so with that, I wish everybody happy Halloween, happy Thanksgiving, whatever you celebrate along the way. And we'll be meeting up in anticipation of all the joyous holidays of the end of the year. And with that, it is now 10:55. And so once again, we have not gone over, which for no small part because of me. I tend to be verbose, but thank you all. Have a wonderful rest of the month, and we'll see you in December. Stay well.
And Perry, just one final announcement from the Department of Health is we are working on scheduling a visit to a processing facility, and it's looking more like that'll be in December, although I know December is a busy month for people, and also people take time off during that. We're looking at one of the Fridays in December, the early Fridays in December for that. And also later this month, we'll be evaluating the applications for the 15th Rural Medical Cannabis Pharmacy license. And so that is something that the department will be doing later this month, and we'll announce the recipient of that intent to award the license in mid-November.
And actually, thank you, Rich, for bringing that up in the last minute. I think I would love to start the December meeting if we can get this as the agenda now starts to shape up. Melanie and Rich and Sarah, we'll talk about this more. You will have done the sort of a report on the Center for Medical Cannabis, Rich, so it'll be in front of you. I think it would be very helpful if you would give a 15-20-minute summary of operations and where we stand, including the number of pharmacies,
Sure.
the number of qualified individuals, of the in terms of people making recommendations, as well as those additional I can't remember the official title, but the non-qualified, but the additional ones, since the last legislative session allowed for that. So there's a lot of things operationally it would be great for us to catch up on and understand, as well as some of the whatever data we can cull from the database as it currently stands. So we'll start with that, and then we'll move to more deliberations about our strategic plan in real time in December. And with that, I say, let it rain, let it snow every day until we see you again.
Yeah.
All those reservoirs. Bye-bye, everybody.